Hi guys, good morning. I'm going to be talking about a patient that I saw last week in rounds. So this patient initially came into the ER complaining of abdominal pain. So this is a 59-year-old female patient that was admitted to the ICU 15 days ago prior to when I saw her. She was complaining of severe abdominal pain, nausea, vomiting. She was vomiting coffee ground emesis and constipated for a week. So the patient has an extensive GI history to include Crohn's disease, hiatal hernia, IBS, GERD. She had a partial colon resection secondary to her Crohn's disease. She has a rectal prolapse and gastric ulcers, for which she sees a specialist, a GI doctor, and she gets an endoscopy every 6 months. So upon admission to the ER, she went to the CT of the abdomen and pelvis, and then it showed some free air and free fluid in the abdomen, so they diagnosed her with a perforated abdominal viscus. The patient was taken emergently to the OR for an X-lap, and it confirmed the perforated gastric ulcer. The patient has since then had multiple surgeries. On the 29th of October, she had a primary suture repair of the perforated gastric ulcer and abdominal washout, and then she was left open at that time. The next day, on October 30th, she went for further X-laps and washouts to repair the perforated ulcer, and then they put an aphthera wound vac. And then she had her last surgery on November 1st when she went for her final washout and placement of a geogynostomy tube. And then the patient was difficult to extubate and remained intubated until November 3rd, when she was finally extubated, but she had some complications, so she required re-intubations later that same day and remained intubated until the morning of November 7th. The patient suffered from delirium, requiring a 1-to-1 sitter for safety as she was trying to exit the bed and remove all attached equipment. She was weaned to room air on November 11th, and now she's alert, awake, and oriented ×4, no longer delirious. She's ambulatory with assistance, and she's tolerating PO. As far as past medical history goes, this patient has a history, like I said, of Crohn's disease, diabetes, migraines, COPD, hiatal hernia, irritable bowel syndrome, GERD, rectal prolapse, and gastric ulcer. She also has a history of bipolar disorder, depression, and restless leg syndrome. As far as surgeries go, she had a hemicolectomy for Crohn's disease, and that was in May of 2014. Her home medications include Seroquel, 100 milligrams daily for her bipolar disorder, amitriptyline, 100 milligrams daily for depression, ropinirole, 4 milligrams at night daily for restless leg syndrome, and Montelukast, 10 milligrams daily for asthma, COPD, and then her omeprazole, 40 milligrams BID for her ulcer. As far as allergies, she doesn't have any known drug, food, or latex allergies. Her social history: this patient lives at home with her husband. She has 3 kids, 3 daughters, and they all live out of town. Her and her husband are both retired. She does smoke. She still smokes 5 cigarettes a day for the past 25 years, and she denies drinking or any other drugs. Family past medical history: her mother died of breast cancer, and she had a history of diabetes, hypertension, and CAD. Her father deceased as well. He had a history of heart disease. And like I said, she has 3 daughters. They're alive, and they have no medical problems that the patient could remember. Review system: constitutional. The patient denies any fever, chills, or weight loss. The ENT: patient denies difficulty hearing, sinus problems, runny nose, pulse nasal drip, ringing in the ears. Cardiac-wise, the patient denies any chest pain, palpitations, or shortness of breath. Respiratory: patient denies cough, wheezing, stridor, shortness of breath. GI: the patient did complain of abdominal pain, vomiting, constipation, but denies bloody stools or emesis. GU: she denies any painful urination, any frequent urination, or urgency. Musculoskeletal: the patient denies any joint pain, aching muscles, or swollen joints. Neuro-wise, patient denies headaches, confusion, change in mental status. Psych-wise, the patient denies any insomnia, irritability, depression, anxiety, or hallucinations. As far as the physical exam goes, general, she was clean, well-groomed, thin. She's age-appropriate mentation. She was interactive. Vital signs, she had a tempo of 100.3, her heart rate was 104, respirations of 23, blood pressure 119/83, SpO2 was 93% of room air. HENT was atraumatic, normal cephalic, the trachea was midline, the eyes were bilaterally symmetrical, perla, scleras white, not edematous. Ears on inspection are both ears are symmetrical, tympanic membrane are pearly white, no erythema noted. The nose is patent with no drainage noted. The throat and the mouth the oral mucosa is dry and pale but intact. Respiratory wise, she has a normal respiratory rate and rhythm. Lung sounds are clear to auscultation in all lobes. Negative for wheezing, rhonchi, or rales. No accessory muscles or retractions were noted. Cardiac wise, her heart sounds were auscultated with no abnormal or extra sounds heard. No murmurs, no gallops, no rubs. Regular rate and rhythm. S1 and S2 were auscultated. Cap refill is less than 3 seconds in all extremities. No significant peripheral edema was noted. On GI, she had a visible scar. She just had an X-lap, so she had an incision in the midline. Auscultation was great. All bowel sounds were normal active in all quadrants, and she was a little tender to deep palpation diffusely, and she is having mushy stools as per patient. GU, she voids, there's no vaginal discharge, no CVA tenderness. Neuro-wise, the patient is alert, oriented to place, time, and situation. She follows complex commands. She's got a GCS of 15. The skin is warm to touch, no masses, lumps noted. The skin is warm and dry. There's some scattered bruisings to the bilateral upper extremities from previous IV attempts. There's a midline incision in the abdomen, like I said, it's closed with staples. The edges of the wound are well approximated and appear healthy. There's no dressing covering the incision. There's no exudate, no signs and symptoms of infection. Psych-wise, the patient is pleasant, making good eye contact, and her mood is congruent with her. Her lab work was, her sodium was 140, potassium 3.9, chloride of 113, CO2 of 20, BUN of 20, creatinine of 0.9, glucose of 173, white count of 9, hemoglobin of 8.8, hematocrit of 27.4, platelet of 345. On admission, when she had a CT of the abdomen, the impression showed a free intra-abdominal air with grossly distended gallbladder, hepatic stenosis, and moderate ascites, with a 44 millimeter pelvic abscess, dilated colon loops with significant stool, no pneumatosis, and a non-obstructive 9 millimeter renal calculus. So the assessment and plan for this patient, the main diagnosis is a chronic or ulcer that had been perforated. So the patient has a history of gastric ulcers, presented with severe abdominal pain, nausea, vomiting, and constipation. The CT did show the free air and fluid consistent with the perforated viscus, which they then took her to surgery for. The perforation was repaired. The next diagnosis was sepsis due to enterococcus, and initially the blood cultures came back as yeast, so she was treated for a yeast infection, but then lab called and notified the infectious disease physician that the positive blood cultures were actually enterococcus gram-positive cocci. So the plan was to discontinue the cefepime, flagyl, and fluconazole that the patient was initially on. So the plan is to repeat blood cultures, urine, and sputum cultures prior to beginning vancomycin and micafungin. So we're going to start 1 gram of vanco IV daily per ID recommendations, as her blood cultures were positive 4 out of 4 for enterococcus species. Vancomycin was selected despite enterococcus being sensitive to previously described cefepime for 2 reasons: the positive blood cultures and the lack of improvement on current antibiotic regimen. The next diagnosis is iron deficiency anemia secondary to blood loss. The patient initially was, the H&H was lower, but she was transfused, so blood loss associated with chronic gastric ulcer and surgical blood loss. Her H&H is now stable and is trending up, so we're just going to continue to monitor every 6 hours and transfuse for hemoglobin less than 7. The most important, and well, not most important, but what I found interesting in this case is that since the blood cultures grew enterococcus, now they're thinking that this patient might have endocarditis, so they consulted a cardiologist to rule out endocarditis. So the plan is to consult cardiology for a TEE, because TEE has been found to have a lower sensitivity for detection of vegetations as compared to a TEE. So the patient had a TEE, but she needs to undergo a TTE now to get a better look at the heart. According to the American Heart Association guidelines, a TEE is recommended as the initial test to rule out endocarditis in high-risk individuals. Patients in which the window for TTE would be obscured, for example, obese patients, patients with prosthetic valves, patients with pre-existing valvular abnormalities, congenital heart disease, a new murmur, heart failure, or patients with bacteremia from organisms known to be the cause of endocarditis, and for patients who clinicians have a high suspicion of endocarditis. Other orders for this patient, and the plan for this patient is to resume the heparin, 5,000 units sub-Q, Q8 hours for STDs, and STDs for VTE prophylaxis. Lovenox is often the anticoagulant of choice, but it has to be used in caution with patients with renal insufficiency and renal failure. And even though this patient is not in renal failure, she suffered an AKI early in hospitalization and has only recently recovered her renal function, so we don't want to give her Lovenox. We're going to give her heparin instead. She's on Protonix, 40 milligrams IV daily. She's at very high risk for a stress ulcer. She's already had a perforated ulcer, so we're going to have to treat that. And then she's been mechanical ventilated for greater than 48 hours. She's had a diagnosis of sepsis, and she has an ICU stay longer than 1 week, which all puts her at higher risk for stress ulcers. So she's on it not only prophylactically, but because she needs to be treated for her ulcer. We're going to continue the home psych meds for this patient, her Seroquel, amitriptyline, and ropinirole for her restless leg syndrome. We're going to consult PT and OT to evaluate for inpatient rehab and work with the patient on strength and mobility. And last but not least, we're going to continue to monitor the CBC, CMP, MAG, FOS, calcium, and chest x-ray for every day to see if we could discharge this patient. And that's all, guys. Thank you.